All right, it's 2 p.m. I would say I make the soft welcome here. Welcome to today's Fightback session. I'm the coordinator of this virtual event series. And while everybody's dropping in, hi everyone. Let me tell you a couple of words about who we are and the mission that we are on here today. FoundersLane is the corporate venture builder in health and climate. Sven will tell you a bit more about that in a minute. But in the essence, we are approaching today's challenges with an entrepreneurial mind and results-driven action to co-create a better world. And fightback is the word that we coined in this context. Because in these present times of massive business disruption, we want to contribute by hosting these free trusted spaces to equip our business leaders and their companies with actionable insight and advice to not only survive, but really thrive in the digital economy that awaits us. And today's conversation will explore how COVID-19 highlights demand for digital health. And this is really something super spicy, and we have two really remarkable men here talking about this. You will join the conversation with Dr. Sven Jungmann and Daniel Nadrat. And Sven is a bridge builder between science and entrepreneurship, leading the health circle at FoundersLane. So he trades his doctor's robe at the ER with entrepreneurial teams to co-create meaningful health solutions. Welcome, Sven.
Thank you.
And we have Daniel, CEO and co-founder of the European health startup Ada Health, here to ease the current pressure on public health services. Hello, Daniel.
Thank you very much. Hello. Hi. Hello, everyone. Thanks, Lily.
Hi. So I'll be in the chat monitoring your questions that you have for our speakers. So make sure the chat window is up. You have the little navigation bar in the bottom. So just click on chat if you don't see it, so you can correspond with us, and we make sure to get your questions answered. So let me hand over to Sven. Sven, the stage is yours.
Thank you. So welcome everybody, and first of all, big thanks to Daniel for being here. Really appreciate that. This is not about FoundersLane, but for those of you who don't know us, just a quick word. We are a corporate venture builder, and the problem we see is that a lot of the big societal issues in climate and in health are extremely difficult to challenge or to take on for most of the startups. And I think Ada is one of the exceptions who really managed to jump a lot of the entry barriers, but in many cases it's very difficult. And at the same time, you have large corporations all around the world with a lot of strong assets that we think they could leverage and bring out in the world by connecting with entrepreneurs and through an asset class basically that has a proper setup that goes beyond your typical design thinking and innovation labs and everything to really launch new businesses using their unfair advantage. And so I'm being in charge of digital health and therefore particularly interested in everyone who has strong experiences in that. I'm very pleased that Daniel is here. Daniel is an interesting person, and I think most of you would know him, who is a lawyer by training initially, did an MBA, worked in various quite successful startups, and then founded his own together with two co-founders, a medical doctor and someone who has a strong background in science, neuroscience, etc. And leads with Ada a very large, very interdisciplinary team, which is necessary to be competitive in this really complex space. Yeah, but with no further ado, I'd like to start our conversation. And maybe, Daniel, could you tell everybody a bit more about what it is actually that Ada does? I'm sure a lot of you people will know, but maybe just to give an update on where we stand now and give people an idea of what it is for those who don't know it yet.
Sure, thanks, Sven. So Ada's vision is to help to contribute to creating a world where everyone has access to the healthcare they need. Ada was founded in Berlin over 9 years ago. We initially started by supporting doctors in their decision making, in their diagnostic decision making, and eventually about 3.5 years ago, we decided to make the technology available to patients as well in the form of an app that works pretty much like as if you had the ability to have a WhatsApp chat with your trusted family doctor 24 hours a day, 7 days a week. So if in the middle of the night you're not feeling well, you could basically send a message to Ada and say, this is my presenting complaint, and then it would have an automated dialogue with you and at the end of this give you an idea of what condition might be causing your problems, but also gives you some suggestions on next steps to take to address the problem. And this app has now been downloaded over 10 million times to become at some point the #1 app in the medical category in the Google Play and iOS app stores in 140 countries. And right now, every 2 or 3 seconds, someone somewhere in the world enters a new case in Ada. Yeah, so that's for a quick introduction what we do.
It's pretty impressive. Could you share a little bit? I don't know how many people know that story. How you just mentioned that you started with specialists and then you went to the patient. So there were quite a few pivots in between. Could you share some of these insights?
Yeah, I always try to sell it as not a pivot, but a strategy refinement. But yes, so we did initially start working with specialist doctors. That's where we sort of, when the original idea of my co-founders, as you said, is 2 scientists, one of them a practicing medical doctor, was really to help doctors in their decision making. Of course, ultimately, it's already about helping patients. But at the time, you have to consider that digital health and especially sort of patient empowerment wasn't as advanced as it would be nowadays. So 9 years ago, we started working with a specialist neurological clinic in Munich in Germany, where we basically helped them diagnose vertigo and dizziness, sort of severe vertigo diseases, even better than they already could. And they are already the leading hospital in Germany for this. The head of this department told us that the accuracy of what we had developed for them was already good enough that a new junior doctor who would join the department would need about half a year to sort of get to that level of accuracy. And then we felt encouraged and said, why don't we basically hire a lot of doctors, train them in creating more medical content and basically cover everything that a family doctor would cover, because they kind of need to know everything. They have limited time, and that's where it gets tricky, especially when it comes to uncommon and rare diseases. So that's what we did, and over several years we increased the medical knowledge base further and further. Worked with general practitioners, mostly in the UK and in Germany. Again, the feedback was really positive on the accuracy, but we also realized that the real beneficiary and the strongest need is on the patient side. If you think about it, 8 out of 10 people Google their symptoms before they go to the doctor. Nowadays, the patient journey doesn't really start in the waiting room of the doctor's office anymore, but it really starts on your smartphone or your computer at home. And while Google is an amazing tool for generalized information search, we felt that there was a gap, because Google, while it knows a lot about you, it doesn't really know as much as a really good doctor would know after taking the patient history properly. And if you think about what Ada does, it is really almost like an automated taking of the patient history. It's a dynamic sort of anamnesis that Ada takes, and we feel that that's a significant improvement over what people get when they use Google to Google their own symptoms. And it's actually one of the most common comments we see in the reviews in the app stores, where, by the way, Ada by now is the most rated and reviewed medical app ever in history, globally, apparently, with well over 300,000 reviews, over 250,000 5-star reviews. And one of the most common things we see there is that people say, this is so much better than Google symptoms. At least it doesn't tell me I'm just about to die. So we see that quite a lot.
Thanks. And has any of that changed during COVID? Do you see anything different?
Yeah, so what we saw, we have a partnership and a joint venture in China where Ada is now also available in Chinese. So because of that, we kind of got an early glimpse into what was going on from the roughly 40 people who work for us there in Shanghai. People, as most people know, they went into early lockdown early this year. So we started modeling COVID-19 as a disease in our disease database. But that's kind of the beauty of a system like Ada, is that you can learn and adapt it quite dynamically over time. So in the beginning, the biggest risk factor if you were using ADA outside of China would have been, have you been to China, or specifically the Wuhan region? And as everyone on this call knows, unfortunately, that became less and less important over time. And we learned more about COVID in the process as well, like things like the loss of smell and taste, that was quite a strong indicator. So as we learn more, we can sort of refine the system, and thereby it becomes more and more accurate. And certainly we also saw a certain surge in usage. What we also saw was that people had a desire to use ADA or to approach us simply not because they wanted to enter symptoms and find out what might I have, but specifically they came and said, could I have COVID? Could I have coronavirus? So we actually reacted quite quickly and developed a separate product, which is a specialized COVID screening tool. And as the pandemic progresses, we're now seeing different needs and different use cases. We are being approached quite a bit by very large corporations and also governments, where these large corporations, for instance, need a back-to-work solution. They say, okay, well, we've now learned more, we know more about physical distancing and all the sort of measures that can be taken, but we kind of want to give our employees, which in some cases of the organizations who contact us might be hundreds of thousands of employees, we want to give them a solution that makes it a more responsible act for us to ask them to show up again at the workplace. So as the pandemic evolves, the requirements for us also keep evolving.
Nice. So I think what's interesting about that is that there's a front end where basically the patients, maybe the doctors and so on, have an informational need and they can satisfy it through this tool. But there's also this backend part, because you keep collecting data and you might find new symptoms like loss of smell or something that then could be brought to the medical community and informing them about something that probably they didn't know yet. And you can accelerate sort of this working up of a pandemic, or maybe of doing surveillance for drugs where they have new adverse effects and everything. And that's also quite, I think, quite interesting. Do you notice if there's any changes in market demand for digital health solutions like yours?
Yeah, certainly. So I think a lot of the people who are listening to this, I think, are somehow involved in the digital health industry. So most of you have probably noticed that specifically telehealth solutions are in quite high demand, where people still want to have an ability to connect with the doctor, but can't necessarily physically see the doctor because everyone's in lockdown at home. So there has been a strong surge, similarly to how there has been a surge for the tool we're using right now for Zoom in general, specifically for the doctor-patient interaction. Some people have actually said, sort of industry analysts, while obviously the pandemic is a horrible thing, it has accelerated certain adoption trends within the industry, basically done within months what hadn't happened in sort of 10 years before, although the technology had already been there. And the other thing that we're seeing is that telehealth, while it's, as we see now, a very useful thing and a great thing, can't solve all the problems globally because there simply aren't enough doctors. So we're seeing quite strong demand. And also telehealth companies actually reach out to us because they can't handle the demand. So they need an automated solution like ADA in combination with the telehealth, kind of as a filter before people get to the human doctor. ADA can certainly help filter out the cases where direct human interaction is not necessary.
I agree. So I recently was approached by a cardiologist who works in a hospital, and he said, I have 3 problems now. The first one is, so I have patients who have heart problems and they're already weak, and I must protect them against COVID. So my first problem is I can't have people in the waiting room who really shouldn't be there. And then he asked for exactly this. He said, the second problem I have is I need to make sure that I can separate the people who have to be in the room quick enough And the nurses obviously do that, but then you have big queues and everything that could help optimize this process of allocating people maybe in different rooms and so on is also important. And then he said, I have a third problem, and that is if I have treated my patients and I send them home because, I don't know, they had like some heart intervention or something and they still need follow-up and they're still weakened, then I realized that there are only very few people that I actually really need to see physically again. And even patients start to realize that. So how can I make sure that I only send those people back into my hospital that I really need, and maybe the others I can see through telehealth, or maybe not see at all if they don't have anything. I don't need to bother them. So I think exactly what you say, even if you combine it with the existing physical infrastructure, has a lot of value and a lot of aspects to do with patient safety in many ways. And that brings me to another question around how do you integrate into a healthcare system? Do you have any words of wisdom or lessons learned or ideas on that you could share?
Yeah, I think there I have to say a lot of things have been developing really in a positive direction in the last few years. When we started out 8-9 years ago, even my close friends were asking, what are you even doing? I mean, it was really difficult to explain to them what we were working on. Whereas nowadays, in the large healthcare systems, we're seeing more and more people who I would describe as digital natives, and who realize that the concept of having a digital front door provider such as Ada really can help reduce cost significantly, also increase patient engagement, and most importantly, improve outcomes by getting people to the right diagnosis faster. To give you an example, we work with a health system in California in the Bay Area, which is called Sutter Health. Mm-hmm. And they use Ada as kind of a digital front door to their service, where they integrated the Ada functionality embedded into their app and their homepage. And they're very pleased with this partnership, just extended it. And they tell us that especially out of office hours, their patients perceive it as a really useful service, a value-add service, because it eases their mind, or where their mind shouldn't be eased, they're being directed to the right next step within the ecosystem of the partner. So what we're seeing now is that more and more health systems across the world are actually contacting us and asking to work with us. What we also see is, however, that the expectations go up. So certainly in terms of integration with their existing systems, they would like to have as seamless an integration into their workflow as possible, which is very understandable because their time is scarce. What we do see is that when you use something like Ada on the patient side, and then you use the outcome of this pre-assessment to already pre-inform the healthcare professional, for instance, the doctor who then sees the patient, whether that is in a telehealth context or in a face-to-face context, that can actually also create additional efficiency by saving the doctor time. Because the doctor doesn't, in this case, start from like a blank sheet of paper and the patient is a completely unknown entity to them, but they would already, through Ada's pre-assessment, know this is the constellation of symptoms the patient has reported. Based on that, these are the most probable diagnoses, but also in some cases where there's an exceptionally strong fit of the constellation of symptoms, for instance, to an uncommon or rare disease, we could already flag that to the doctor. And we would also give the doctor some hints on which investigations, examinations, or tests they should consider next to get to the ultimate diagnosis. And best of all, from the doctor's perspective, I know they really like this, because it's all structured data. We now cover about 26,000 ICD-10 codes. It can be imported into their system, so most of the documentation is really already done. They just need to do the delta of what an automated system wouldn't be able to do, like a physical examination, for instance.
Okay. We have somebody asking a question, actually, if it's fine. David Newman Toka says, is Ada a purely expert content-driven app, or do feedback or has it feedback and learning incorporated? If the latter, then how do you get the feedback on correct diagnosis into the system and verify that they are correct?
Yeah, I think that's a great question. Thanks, David. So it's really two steps. So the way we built the system really is a little bit different from maybe some others who tried to build a medical knowledge base, for instance, based on billing data from a health system. If you ask any knowledgeable sort of health system expert or even doctors themselves, they will tell you that what's in the billing system isn't really the medical truth necessarily. It's basically what's written down there as diagnosis is a reason for, for billing, but unfortunately doesn't always reflect what the patient really has. It's sad but true. So the way we chose to build the system initially was to use expert knowledge. So we have a quite sophisticated medical content creation process where we have an internal team of experts. We have about 60 doctors from 20 countries who were trained at Harvard, Cambridge, Charité in Berlin, some of the best schools. And they initially created the medical knowledge base. But then on top of this, of course, we want to use the, by now, almost 20 million cases in the system and the constant flow of new cases to create what we would call a virtuous cycle of feedback loops. So to answer your question, how do we get the feedback in? Just to give you a few examples, there's some really basic feedback loops where we would ask the patient a few days post the assessment, how are you feeling? Are you feeling better? Have you actually seen a doctor? And if so, what diagnosis did the doctor give you? Now, this is somewhat of an imperfect feedback loop because unfortunately we don't know how good the doctor was, right? Even the best doctors commit errors. So we need to sort of apply certain machine learning approaches and statistical analysis to really not automatically adjust our system, but it's supervised learning. And we would also like to add other feedback loops such as lab test results and so on. So there's quite a few different feedback loops there.
Yeah, that's clever. I remember, so when I was in the emergency room and I had, as a practicing doctor, and I had somebody with a heart attack, then the system would ask me, please give in all the diagnoses. And it was so cumbersome to do it because the system is from the 90s that I always just typed in pain without any other comments or remarks. And then it would just let me leave and take the patient to the ICU or wherever. And that causes a lot of problems. So yeah, there's the billing problem, there's the user design problem, user interface design problem. And I think taking the circumvention approach is something that would really add value to the system. I think that the second question, maybe more generally asking, is like, how is the evidence base in general on diagnostic tools and AI and diagnostics? Do you have any insights on that?
Yeah, I think so. There have been various sort of comparisons that were published in the past. For instance, there's one that has been done by a medical doctor who works at Microsoft in the research department, and she compared ADA to a few other systems. And she looked at three things. Basically, does it give the right triage advice? Does it ask the right questions like a good doctor would to rule out more serious or life-threatening diseases? And thirdly, is the right diagnosis somewhere in the top suggestions? And this was published, and the result was that unfortunately the competing systems got it wrong on everything, and ADA nailed everything, including having the right diagnosis top of the list. There are a few more. I think there might be about 6 or 7 such independent comparisons that were published, including one that was recently published in Pulse, which is a doctor journal in the UK for GPs. And the result is always the same. There's also a study that is currently in peer review with the BMJ, which takes 200 sort of textbook medical cases and then ran them through the various systems. But also had a panel of experienced UK GPs go through them, and the results are quite interesting and unfortunately also favorable for ADA.
Mm-hmm. Thanks, Asif. Thanks for your question. I'll get back to it in a moment, if that's all right. Some things I wanted to ask you is, at some point, Steve Jobs famously, was it Steve Jobs? No, it was Jeff Bezos famously said that people always wonder what is going to change and what's the new trend that I have to jump on. And on his view, it's much smarter to base a strategy on things where you think they're going to just stay the same, because that's how you can go into long-term planning. What do you think, in spite of what COVID is bringing in terms of changes that we can't really anticipate, what do you think are the key things that are going to stay the same, that are relevant for digital health innovators? Or for you?
So I think some things will inevitably stay the same. I don't know how many medical doctors are on this call, but sometimes the slightly absurd question comes up. Do you think at some point you won't need medical doctors anymore? And I think the answer to that is obvious, really, to everyone. We will always need human medical doctors, and they will, I believe, always beat machines when it comes to empathy. That will always stay the same. I think that's sort of the most important thing there. I think something else that will not change is that the patients, well, actually that is a change, because currently that's not the case everywhere in the world, but patients will be more and more in charge of their own health, sometimes without even sort of it being a conscious process. So that is a change. Sorry, I was going to say that it's already that way, but that I think would be a change, because that's not the case right now. Mm-hmm.
And then I think, so Asif, this is I think a little bit what you are pointing at, right? He says, so given that there's a greater demand for mental health already before the COVID pandemic, however, we also see more people being isolated, and there's this assumption, or maybe it's even proven, I think, that a lot of mental disorders are on the rise as a result of sort of this isolation and difficulties of getting help. Does ADA have capability to assess, diagnose mental health conditions? And do you work with any mental health chat, virtual consulting providers at the moment? Is the question of Asif.
Yeah. So one thing that actually surprised me over the last few years, because I wasn't, not being a medical doctor myself, I wasn't fully aware of how prevalent these issues are, was that about a third of ADA's cases actually have a mental health component to them already. That was even before the COVID pandemic, including anxiety, stress, burnout, feeling depressed. And actually, one of the things that I also didn't anticipate was that there have been so far tens of thousands of people who told ADA that they want to take their own life. So this was something where we had to consider what we would do in this case, because normally what ADA tries to do is sort of keep asking questions until there is a sort of sufficient level of confidence to show a result, which can be 20, 25, 30 questions. But once someone has told you this, you can't go on and say, well, what is sort of the physiological cause, and keep asking questions. So we hard-coded something where we would there break the question flow, and for the 150 countries or so where we're active, direct the patient. We would recommend to talk to a relative or a friend, and if they don't have anyone to talk to, we would direct them to sort of the national hotline for these kinds of cases. So these are learnings we had to have over time. What's interesting when it comes to COVID, and that's also an interesting case where we can learn from the data, which, by the way, we're also happy to sort of make available in selected sort of research partnerships. What's interesting is we were kind of expecting that mental health conditions would be on the rise because of the pandemic, and we analyzed this, and what's interesting is that actually they slightly went down, and we were trying to analyze this because you would think that there would be cases of isolation and anxiety because of this, but our interpretation of this, and this is not very scientific, but we're wondering if there's also sort of a counter effect, which is the reduction of stress and mental issues, maybe due to fewer work-related concerns and less pressure, these kinds of things. So we're not fully sure why, but we're monitoring this and we keep analyzing this. With regard to mental health chat and virtual consulting providers. So we are in various conversations. As far as the automated chat goes, ADA covers that, but certainly there will be cases where it makes sense to then refer patients to, to basicly specialized telehealth providers who offer telehealth, mental health counseling. And this is one thing that we are planning to do in the future. We're not currently doing that yet.
Mm-hmm. Thanks for the question. Another conversation I think that we also had a few times where the startup community is trying to do something quite a bit, but so there's a general question, there's a COVID related question, but what do you think governments could do? And you're welcome to focus on Europe, if that makes sense, or maybe draw comparisons to the other countries in which you're active. What are some of the things that you think work really well to enable digital health innovation? What maybe should the European governments do differently, do you think? And I mean, we all know that during COVID, suddenly a lot of the barriers disappeared or were lowered a little bit, and there was a clear sense of urgency that could have also been there before. But is there anything where you see it might get better, or this should change so that we can really drive innovation?
Yeah, so I think governments will be well advised to not, due to sort of lobbyist pressure, turn back the clock on things that have been proven to work during this pandemic, because there has been actual sort of real progress with regard to digital health adoption. The other aspect where, normally I was always quite skeptical about what's going on in Germany when it comes to digital health, but where Germany has actually now done a surprising step forward under the current health minister is that digital health solutions are getting a path to reimbursement, which I think provides an opportunity for for an ecosystem leap forward, because there is an actual business model that's similar actually to pharmaceutical products. So there's a sort of an established process that's taken from pharma and now applied to digital health solutions, which, and if you think about it, it makes sense, because the reason pharma products, drugs get reimbursed is because presumably they will have a positive effect on the health of the patient. And what we're seeing with digital health solutions, such as ADA, obviously not only ADA, but such as ADA, they're already being used by millions of people. We see all the evidence, including, I forgot to mention, there's a rare disease study on the effect that ADA can have on much faster diagnosis of rare diseases, which is published in Orphanet Journal, and all kinds of evidence, and certainly the strongest evidence being the adoption by users and the feedback by users. And this is already having a mass positive effect on the health of users. So why would sort of chemicals get reimbursed, but digital solutions wouldn't? So I think this is a good step forward, and I hope that other governments will follow.
Mm-hmm. Good answer, thank you. Ahead of this, someone from Johns Hopkins reached out to me. I think he's not here right now. A gentleman who's a strong researcher in the field of patient safety primarily. And he approached us with an interesting question, and he would like to have answered, since this is recorded. I think that you might be curious later on. And I think it's a generally relevant question. His question is, how will tech change the clinical practice and a medical enterprise operation post-COVID? And he was particularly interested in the art of diagnosis. Do you have any thoughts on that?
Yeah, for sure, because I mean that's basically where we started when we started on the doctor side, even over 9 years ago. It was really my co-founders one of my co-founders had spent decades into researching how the human brain works. I would argue he has a quite well-functioning human brain himself. He's a grandson of a Nobel Prize-winning physicist called Heisenberg. And I suspect something got passed down there with the genes. So his theory is that there's such a thing as subconscious constellatory thinking, where the really good doctors, they even sort of, without even thinking about it, when they see a patient, they see like 5, 6, 7 things at the same time and sort of form a hypothesis based on this. I think David is an expert who asked the previous question, is an expert in vertigo and dizziness diseases. And the first specialist clinic in Munich that we worked with, they explained to me, when you have morbus Meniere, there's this trilogy, this triad of symptoms, where if you have symptom A and B, symptom C means something different from when you only have one of the symptoms. So there's like a sort of a mutual constellatory unfolding. And what we tried from the beginning really has been to mimic the way a brilliant doctor would deal with these issues. And obviously, if you get that right, then that has a significant impact on patient safety. And then basically we kind of, when we created the patient version, we kind of translated that to the patient side. But it's always about supporting the patient and the doctor along the entire journey. So it's really, we don't look at it as a pivot really, because we're still supporting doctors as well. And it's really about connecting the world of the patient with the world of the doctor and making the whole journey more efficient. And we think that it can have a massive impact on patient safety. To give you the example of the rare disease study that's published in the Offnet journal, what was done was a retrospective study on, I think, about 100 patient cases where it took more than 10 years to get to the right diagnosis. And basically what the doctors, the external experts who conducted this study did, was they looked at the first time the patient presented 10, 15 years ago, the second time, and basically entered the information from the patient record that the patient had given into ADA. And shockingly, in over 50% of the cases, ADA would have, had it been around back then, would have flagged the ultimately diagnosed condition the first or second time the patient presented. So if you take that also as a sort of as a measure of patient safety, getting to the right diagnosis faster, then I think there's such huge potential in terms of improving outcomes for patients by applying technology.
Yeah, maybe I can also share some thoughts on from my clinical background. We had regularly something called a conference for rare lung diseases, where doctors would send people from all over Germany to us if they saw patients with something that just seemed odd and didn't fit in any pattern. And we had some senior experts. I was a junior doctor, and I was supposed to be the guy who collects all of the information about the patient. So you ask deeper and deeper, and if any hobbies they may have had, and any jobs that might have been a bit odd, and anywhere they've been in the world, and so on. It takes so long, and you don't really have the time for this. But then you've got it. And then you have to present it at this conference, which takes place every week or every second week. And you feel so well prepared until somebody asks, could it be that he worked in this coal mine? Oh, I'm making something up now, right? But then you said, oh, I didn't ask that. And then been revisited, you have to call the patient again, you have to reschedule for 2 weeks. And this can be a super lengthy process. And there has been an expert opinion in 2003, it's really old, but I still think it applies. And they looked at what they called automated history taking. And found that it allows physicians to gain more data. Patients have more time to complete the interview because they don't feel so pressured. They have more time to look things up again, to think about it. So it can also uncover more sensitive information, because you might be inclined to be more open towards a machine versus a human being. If you feel that they're judging you, you can better adapt it to foreign languages, as you said, right? You're in so many languages. And language barriers in many of the larger cities are frequently a problem for clinicians in terms of getting the right diagnosis out of people. And you can get structured information. So I was writing all of this down, and then it's pretty much gone. But if you are really collecting this, and maybe you can even collect it over time, and then see some moving patterns, I think that's something that I would say might really, really change how we go about diagnosis.
Yeah. So one of the things that we discussed also with our partner Sutter Health in the Bay Area is they have quite a high number of Spanish-speaking people who don't actually speak perfect English. And I didn't mention it in the beginning, but we have, so Ada is available in 8 languages right now, which is English. Actually, it's more because it's US and UK English. Some people are very precious about this. Spanish, Portuguese, French, German, Mandarin Chinese, Swahili, because we work with some NGOs like the Gates Foundation and the Botman Foundation from Switzerland, and also Romanian. And we're adding more languages as we speak. But what's interesting is because it's one platform, you could have the patient enter the information in patient-friendly language in Spanish. So the patient would in Spanish say the equivalent of, I have a tummy ache. The patient wouldn't say I have abdominal pain. And the English-speaking doctor would see abdominal pain on their screen in sort of physician language. And so as you say, this could be another great application of technology where you make sure that nothing gets lost in the process. And if you think about a country like the US, I was trained as a lawyer not only in Germany, but also in the US. So I know it's a little bit more litigious than the rest of the world, also in terms of defensive medicine, documenting both for the patient's and the doctor's benefit that some point has been mentioned and addressed can also be important.
And another thing that I thought about was when I was in chemotherapy, then you always have these 3-week intervals, and then you ask patients, how have you been these last 3 weeks? And sometimes you had patients said, it was miserable, and then they can't really tell you when they were feeling miserable because it's been so long ago and they forgot about the details. And it's really important if you want to give them antiemetics or whatever, that you have an idea of when did what happen, and was it more in the evening that you had a problem or in the morning and so on. And I think also having more contexts in your history taking, and you don't have this recall bias and all of these issues with sort of the human memory, it adds another dimension. And I think, I don't know how many non-medical people we have in this group, but there's this common saying that rare diseases are common because they are rare individually, but there are so many of them that it is actually a very, very common problem. And I think there's great value in potentially trying to connect people globally who have the same rare conditions, and then allow the clinicians to share their experiences with it. Because I might see a person with one rare disease only once in my life. How am I supposed to really deal with that? But maybe if I can exchange my thoughts with somebody in the US and somebody in China who have seen similar patients, we could learn from each other and make the diagnostic process more social. And I can only see how this can work with the basis of good structured data that allows you to match people who are comparable in a way. So yeah, this was another thought that I also had on this really interesting question, I think. Yeah. Are there any other questions in the group? You feel free to chip in. I think I'm seeing something here. No, I think that's done. Any more questions? Please feel free. There's a Q&A button that you can write, or you can use the chat if you feel like typing something. If not, then I would also have one. I wanted to give it to the group a bit. No. There's something up here, I think. No. What is most interesting to you now with Ada? What are we going to expect coming up?
Well, so with Ada, my personal ambition is hopefully within a few years to really address the issue that there are actually billions of people in the world who don't have proper access to healthcare. And I think there's a real opportunity to use technology to kind of for the first time give people who wouldn't be able to afford a doctor, who wouldn't know how to interact with a doctor, to give them something with the increasing proliferation of smartphones that gives them an idea of what they may have, so they can then take next steps. So that's kind of the mass impact that I would be aiming for, would be to eventually reach 1 billion people or more in the world. But the other thing I'm excited about is to keep evolving the product from a currently more sporadic use case for symptom assessment towards taking a lot more data sources, information sources for health information into account, such as lab values, such as sensor data, even consumer genetic data, consumer genetic testing data, as well as data from the clinical health record. And we're working on all these things because our goal, of course, is to make the product more and more and more accurate for the benefit of the patient. And as long as you only rely on patient-reported symptoms and findings, you always hit a ceiling at some point. It would be the same for a human doctor. And I think this is a really exciting space because the more different data points you have to put together, the more an automated engine will have an advantage compared to what can currently be done, especially if it's connected to a continuous monitoring and measurement. So my ambition for ADA would be to really become kind of an operating system for personalized health that can act in a way where it doesn't react sporadically to problems when they have already manifested themselves, but ideally would sort of spot weak constellations of signals at a point in time when maybe it's still a $100 problem and not a $100,000 a year problem yet. And I think the opportunities there are amazing, and we really, the thing that drives us is the user feedback that we get every day in the app stores or directly when people say, this saved my child's life. We wouldn't have gone to the hospital if we hadn't used your product. Or the people who say, I have a rare disease. It took over 15 years. I've seen over 20 doctors and I knew my diagnosis, wanted to test ADA, and ADA told me in 5 minutes what 20 doctors needed over 10 years for. That's the kind of stuff that we see, fortunately, all the time and more, and that really motivates us to keep going.
Mm-hmm. Cool. Then maybe one very final question. I know we have a lot of international people here attending, and I think Germany, except for some exceptions like yours, hasn't been particularly well known around the world for digital health innovation so far. Do you think that's going to change? Are we going to expect more things coming up in e-health from Germany, more innovations?
Yeah, so before the pandemic hit, I was in the fortunate situation to spend quite a bit of time. I lived in the UK for a few years. I also spent quite a bit of time in the US, specifically in the Bay Area. But also in Asia. And so I've seen a lot of digital health efforts around the world. And I have to honestly say that I don't think that innovation only comes from the Silicon Valley. Specifically in this space, there are amazing and really impressive digital health startups and founders everywhere in the world, including Germany. And I think we're just at the beginning of a longer journey, and we feel very fortunate to be part of this development.
Nice, thank you. So if there's no other questions, I'll give it
There's another one in the Q&A.
It's David again. Thank you very much, David. Do you want to read it?
Sure. So it says, ADA takes a self-administered history. What do you see as the future of doing self-administered physical examinations?
Oh, wow.
Sven, maybe that's one more for you.
So this is potentially science fiction, but I have seen like doctor boxes where they let patients sit in a box, and there are some basic diagnostic tools, and they would start with, I don't know, blood pressure, etc. There are people thinking about, could we have smart mirrors that have a camera which can maybe detect if you might get melanoma somewhere. So if some of your skin suddenly becomes in one way or another a bit changes and there's some alteration. I know that Leo Pharma, it's a Danish pharmaceutical company quite focused on skin care and dermatology. They started something where you can, with your phone, take pictures of your diseases, put on obviously the Leo medication. You could also do it with others, but that's a little bit the idea that they sort of have beyond the pill or beyond the cream digital solutions on top. And that guides you and tells you how well you're doing with the treatment. At the same time, it allows you as a patient to pretty much donate your data and partake in clinical trials, which is a similar concept to what Daniel just said earlier, and thereby advance the science as well. And I think that's quite a clever thing to do. There are a lot of theories around increasing a role of ingestibles and wearables and everything that you could think of being possible to measure. Blood sugar being one of the interesting candidates, and so forth, I think could lead to sort of very new, interesting possibilities. We've once seen a technology that promised to do long-term real-time blood pressure management or measurement without any cuffs, which in the end of the day, I don't think was reliable, but we were playing around with the idea, and we interviewed a series of doctors and asked them, assuming you had the possibility of getting second-by-second blood pressure measurements, would that be of interest to you? And the doctor said, you know what, I wouldn't want that because I don't have any guidelines that tell me how I should interpret that data. It's not actionable for me. I'm not sure if this is better than take one blood pressure measurement in the morning, during lunchtime and in the evening for a couple of days, and then I know how to adjust your medication. I don't have that reference for interpretation for 24-hour real-time measurements. I don't know how to interpret and how to activate. So I think technology will make a lot of things possible, but then the evidence will lag behind on how to interpret these sorts of things. And I know blood pressure is probably a bad example, but it will in all likelihood account for many other things as well.
Yeah, so I've seen some really interesting developments in the sensor space. One of our new investors is Samsung, and Samsung's global chief strategy officer has joined our board, and I've looked at some of the work they're doing in the sensor space, and I think we haven't yet seen all the things that can be done in the future. I've also separately spoken to people who have developed quite interesting sleep sensors where you would have that, you have sensors in rings, and I think the stage of maturity in the market where we're at is that currently most of these solutions are relatively siloed and have like a single indication that they're medical indication they're developed for. But this is where I think in the future you will see that there needs to be sort of a holistic medical brain that sort of normalizes all the data coming from all the different sensors and sort of makes sense of all of that for the benefit of the patient. So I can see a lot of possibilities there. I'm also looking at a startup here in Germany that has developed some in-ear measurement sensors specifically for COVID, for people who have the coronavirus disease, to sort of monitor them. And I think we're just seeing the beginning of some amazing possibilities.
I agree. Well, I guess it seems like people are out of questions for now. Do feel free to reach out afterwards. I think Vincent of Ada also shared an email in the chat. If you want to reach out there, you can contact me. And I thank you very much, Jen. It's always good talking to you. And I thank everybody for their questions and for spending time with us. And have a great rest of your day.
Thank you, Sven. Thank you, everyone. All the best. Stay healthy.
Lily, do you want to?
Hi, yes. So thank you so much for joining. If you want to explore our upcoming sessions, go to sessions.founderslane.com/next. Thank you so much, Daniel and Sven. The session is recorded and we're going to upload it soon and share it with you to review and take some bites out of it. Thank you so much for your time and have a great rest of the day.